Hi, it's Manesh Patel here from Duke University at the Heart.org booth in Orlando at the American Heart Association's 2011 meeting. I have the pleasure of talking to Dr. Kang from Korea about the EASE trial, a study around infective endocarditis. Thanks for joining us.
Thank you.
Can you tell me about what led you to do this study?
In spite of advances in medical and surgical treatment, infective endocarditis remains a serious disease that carries considerable mortality and morbidity. Previous clinical studies showed conflicting results, and they had significant limitations of baseline differences, treatment selection bias, and hidden bias even with propensity score matching. To overcome these limitations, we designed a prospective randomized trial of comparing clinical outcomes between early surgery and conventional treatment strategy in the treatment of infective endocarditis.
Wow, so that's a significantly difficult trial, it sounds like, to conduct early surgery versus conventional therapy for patients with infective endocarditis. How many centers did you have and what did you find?
This was a prospective open-label randomized trial at 2 centers in Korea from 2006 to 2011. The primary endpoint was composed of in-hospital deaths and embolic events that occurred within 6 weeks from the randomization. There was one in-hospital death and no embolic events in the early surgery group, and one in-hospital death and 8 embolic events in the conventional treatment group. The primary endpoint occurred in 2.7% in the early surgery group as compared with 23% in the conventional treatment group. The difference was statistically significant. The secondary endpoint included all-cause death, embolic events, recurrence of infective endocarditis, readmission due to congestive heart failure at 6 months follow-up. The event rate at 6 months follow-up was 2.7% in the early surgery group and 28% in the conventional treatment group. The difference was also statistically significant. The EASE trial, the first randomized comparison trial, showed that early surgery significantly reduced the primary endpoint by effectively decreasing systemic embolism in the treatment of infective endocarditis. Moreover, these improvements in clinical outcome could be achieved without increase of operating mortality or recurrence of infective endocarditis.
Wonderful. So your findings are that, in fact, early surgery seems to clinically benefit patients from reduction in systemic embolism.
Yes.
Well, thank you so much for joining us and providing this important information for our clinicians and patients.
First, it was clinically feasible to perform
Yes.
early surgery within 48 hours of the diagnosis of infective endocarditis.
Yes.
Second, early surgery can be a therapeutic option to further improve endocarditis, to further improve clinical outcomes of endocarditis, which is still associated with considerable mortality and morbidity. Finally, we hope that our randomized trial is just the beginning of larger randomized trials to provide definite evidence in the treatment of infective endocarditis.
Great findings, and thanks for putting it in perspective.
Thank you.